too basic, let me know. I can change it up and I can present the same thing again next month if you want. But I thought of going through Diplopia, which is what you requested. A little bit on pupils and a little bit on common neuro-ophthalmic presentations. So Diplopia is double vision. It's quite important to get the history right because often even we see patients in clinic and they're like, oh, it's blurry. You have to ask, are you actually seeing 2 instead of 1? There should be 1 pen, but are you seeing 2? Because often you can get, it's like a ghosting. You see an image and it's a bit blurry and then there's like this blurry halo around it, and sometimes some people think, oh, it's double, but it's not. And there are various causes. I'll go through them. Neurological, refractive, meaning due to the cornea or the lens, and ocular surface, so cornea mainly, dry eyes and things like that. And then just, is it really double or is it just blurry with ghosting? And then the other thing to check for and ask as well is, are they noticing it with both eyes open or is it only with one eye? So we often, if they ring us up in the clinic, we often say, right, close your right eye, is it still double? Close your left eye, is it still double? Because the causes are different, and that just helps us to think, okay, is it neurological, is it not neurological, how soon do we need to see the patient, and what are the underlying causes. So next slide, and then from the history, when did it start, how long has it been there for, does it come and go, because that could be, we would think about something like, could it be like myasthenia causing muscle weakness, comes and goes, worse at the end of the day, fine in the morning, or does it get worse with tiredness? But anything that makes it better or worse, and is it gradually getting worse, about the same? And then other associated symptoms, so just thinking about the eye, is there pain, is there any headache? When you think about headache, I normally just ask about nausea and vomiting straight away because you're thinking about space-occupying lesions. And then you would want to know if the vision is affected as well with the diplopia, because that makes you think about, could it be a refractive cause or an ocular surface cause rather than a neurological cause. So in the examination, when you're looking at them, it's good to just make any observations about their face. Have they got ptosis? Have they got a Bell's palsy? It might or might not be related to their diplopia, but it's good just to make a note of it. And then whether you can see any obvious deviation. So is the eye turning all the way out that way when it shouldn't be, or in, or is it up slightly? Just any gross sort of observations, and just note that down. And then just basics, just vision, pupils, and then extraocular movements in the H. I think everybody knows that. So make sure they're not moving their head. Sometimes you might have to just keep their head in place, and then just get them to look at the tip of your pen or something and just watch. Normally what I do, and I think it's quite helpful, is to ask them specifically at each point. So you start in the middle and you say, is it double now? And is it side by side or up and down? Fine, then that's what they've said. And then we document, so I document sort of like a H as well. I'll just draw it here for you. Well, it's not exactly H, but that's what I would document. Don't know if it's coming clear in the video. And the center box is what I would draw. So if it's double there, then 2 sticks, yeah? And then I just keep going in every position. So then I'm like, okay, now go this way. Is it double there? No. Now go that way. Is it double? No. And then you can do it side by side if it's horizontal. You can do 1 up, 1 down if it's vertical. Sometimes some patients have very complex diplopia. It's side by side over here, up and down over there, depending on whatever the cause is. So that's just quite a good way for you to just draw it out. And you draw it out in, if the patient says you're facing the patient says, oh, it's double here, then you just draw it on the left. And when you're looking at it, it's when they're looking to their right, because it's the opposite. So that's just quite a simple, easy way to break it down. And then you can think about later which nerve is it probably. You can think about that later. Just draw it, write it down as you see it. And then just make a note which direction and whether it's vertical or horizontal, because that gives a clue on which nerve might be involved. So next, okay, so this is the bit about how to differentiate, well, when you find out from the patient if it's monocular or binocular, then you think, what are the causes? Generally, monocular is not due to anything neurological. It means it's coming from the eye. The double vision that they're getting is coming from the eye. So it could be astigmatism, problems with the cornea surface, so if they've got some scarring, or if there's edema, maybe they've had recent cataract surgery and the cornea is very, very swollen, or if they've got an opacity, or any abnormal shape of the cornea, and similarly from the lens as well. If they can have double vision, for example, even if they've had cataract surgery, but then the lens has displaced, the lens has fallen, lens has moved. It's not uncommon, it does happen. We do see patients with lens problems. And then iris defects, quite rare. I've not seen anyone with diplopia from an iris defect. It'd have to be quite a big defect. But just monocular means it's just ocular, it's coming from the eye rather than nerves and neurological. Now binocular depends on, I guess the way you can think about it is, the duration of the symptoms. Is it persistent, or is it intermittent? So like I mentioned earlier about the myasthenia, patients with MS, with demyelination, their symptoms come and go. I was looking in the literature and it says GCA, giant cell arteritis, can cause an intermittent diplopia as well. And then neurogenic, if it's just there and it's constant, not changed, not better, not worse, just there, boom, it happened and it stayed the same. And the mechanical, so if they have like thyroid eye disease, any trauma, myositis, inflammation or infiltration affecting the globe. Okay.